So neratinib is also used in the setting of higher risk disease. And again, like other therapies, we try to project what is this patient's risk of recurrence, and then based on the hazard rate reduction that we project with that drug based on the clinical trials, we can calculate what their absolute benefit would be. So yes, in this patient, I believe they have a high enough residual risk, even with all the therapy they're receiving, that I believe the addition of neratinib may add a few percentage points more in lowering the risk of recurrence. Well, there's several different directions that are being taken with improving outcomes in HER2 positive breast cancer. Metastatic recurrences remain incurable, so our goal really needs to be to keep that number as low as possible with an acceptable risk profile, of course. And so the addition of other therapies that may complement these drugs is always going to be important. But then we also have to realize that these drugs have side effects, there are costs, there are convenience effects, so we don't want to just keep piling on more and more drugs. We would like to be at a point where we can personalize therapy and know which patients do or do not need drugs. And so that falls into two general areas. One is understanding and discovering biomarkers that may predict who will respond to specific drugs. One example of a biomarker is PI3 kinase mutations, which seems to indicate some degree of resistance to trastuzumab and maybe to pertuzumab. It's not really clinically used right now, but we need more biomarkers like that, and they need to be validated. And then, of course, we also need to look at other factors that predict who might be at higher risk for recurrence, whether it's stage, whether it's other clinical features. And this will help us be more precise. The other movement that's going on in this area is, are there patients in which you can de-escalate therapy? Someone who looks like they're going to have an absolutely good outcome and might not need the full year of antibody. And at this point, we don't know that, but there are some discussions about taking patients, not with inflammatory cancers, but maybe who start off with node-negative cancers, who have a complete pathologic response, and maybe they don't need to complete the full year of maintenance antibodies. And so those kinds of studies are being discussed as well.